Hello, everyone. We are live and we're extremely excited for the conversation that we're about to have today. I don't know if you saw the LinkedIn post, but we like to think of this William Gibson quote: "The future is here, it's just not yet evenly distributed." So what Ray and Chenlee from Intermountain Healthcare have been doing to help manage chronic kidney disease, CKD populations, we thought that it was a great opportunity for a LinkedIn Live session and a conversation with them about what the program entails, how they're actually managing these populations, and what's actually going on behind the scenes to make Intermountain Healthcare, help make Intermountain Healthcare a leader in value-based care. So we're really excited to have this conversation. I'll go through introductions in a minute. The format that we've been using on LinkedIn Live is so that it's not just a conversation between us, but a conversation with the audience. So feel free if you have questions, comments, or any ideas, anything that you want to share, or if you want to say hi to other people or say tell everybody where you're coming from. Feel free, use the comment section. It's great networking as well as getting answers directly from people who are leading change in today's healthcare challenges. So today we're joined by Chenlee Condie, who is the nurse manager for the Kidney Care Program and has been working with Intermountain Healthcare. Chenlee, for nearly 20 years?
20 years, yes.
Fantastic. And Ray Morales, who has served in multiple roles in multiple capacities, leading on business development and leading on the operational program. Huge history in kidney care, starting with DaVita, but Intermountain for the past, 12 years, was it, Ray?
Yes, 12 years. Mm-hmm.
Great, fantastic. So lots of stories here as far as how we're going to get into how the Kidney Care Program was launched and how it works today. I'm also joined on the SymphonyRM side with Terry Tusnick, who also boasts a huge history leading IT departments, working with Accenture, IBM, various consulting agencies in terms of strategic healthcare engagements. Any word for the audience, Terry, as we go through this?
Glad to be here and really excited about this conversation because I think reaching out to our patients for value-based care and getting them to choose healthier lifestyles is really critical to healthcare globally. So really glad we're having this conversation today.
All right, thank you very much for that. So yeah, for those who've been wondering about operationalizing in a value-based care environment with all these complexities, or those who've been wondering about, hey, what does artificial intelligence actually mean in a practical use case? How does interoperability factor in to practical use cases at all? We're going to have that conversation and more for the next 30 minutes. So just to get started, for those that might not be familiar with what Intermountain Healthcare is doing today, there's actually been a whole lot of motion around the CKD, chronic kidney disease space, especially with things like the Chronic Kidney Disease Research and Treatment Act of 2019. So Ray, could you tell us overall how the department works and what the role is that you guys are playing in managing the CKD population?
Yeah, definitely. So really, this program is built on the foundation of Intermountain's mission, which is to help people live the healthiest lives possible. And that's really our aim with this program, is to build upon that and focus it on those individuals with chronic kidney disease and end-stage renal disease, to ensure they receive a cutting-edge, fully integrated, comprehensive care across the full continuum of care. And so the way this program started was we as we were building the program, really we thought, okay, how do we ensure that we not only put the patient at the middle of the program, but also make them part of it, right? Because that's where you get really a lot of traction, is in engaging both the patient and the caregivers. And so what we've done is Intermountain Healthcare fortunately has very rich data. And by accessing that data, we were able to discover, and part of this process was mapping out the patient's journey. And as we did so, and as we integrated patient data into that journey, we identified some pretty significant gaps in care that needed to be addressed. And so we began by working with a couple of different vendors, one of which was MD Clone, and building a data lake. So pulling all this data together to begin to risk score these individuals and prioritize them in such a way that we could ensure that we were focusing on the most vulnerable and those individuals that needed these services the most. One of the things that we discovered early on, and really was one of the data points that spurred this program to move forward, was the fact that close to almost half of our population of patients end up in the hospital, finding out for the first time they have end-stage renal disease. And this isn't uncommon. I mean, you would find this in multiple health systems throughout the country. And in fact, if you look at just the CMS data, you'd find that 1 in 7 adults has chronic kidney disease. And of those that have chronic kidney disease, 9 in 10 are actually unaware that they have the disease. So this is a really important program that is not only focused on the downstream management of those individuals, ensuring that they get the right treatment options, but really what makes it innovative is our ability to be able to identify and engage those individuals early on before their disease progresses to the point where they may need a transplant or dialysis or some other form of treatment. And so that's really what we're aiming to do, is to identify and engage individuals in a proactive way through predictive modeling, and ensure that they get put on the right clinical care pathway and that we can address their disease holistically across the full continuum of care. And a lot of the way that that's being done is with the SymphonyRM All-Track tool, and Chenlee and the group of nurse navigators, as they're engaging these patients, this tool helps us to be able to track where those patients are on their journey and what opportunities exist for us to further engage those patients and their caregivers and really others that are part of the care team to ensure that we're really taking a fully comprehensive approach to managing these individuals.
Fantastic. And just wanted to give a shout out. Rich Phillips says hello, Terry. So just wanted to.
Hi, Rich.
And Chenlee, going off of that, like Ray definitely hit from the operational perspective. Just wondering, just as far as the overall program and how it works, and with the team of nurse navigators, could you shed a little bit of light on the clinical component?
You bet. So we have phenomenal providers in our clinic, starting with our nephrologists, our advanced practice providers, our clinic staff, and then our nurse navigators. So every patient that comes into our clinic is assigned a nurse navigator who's going to follow them longitudinally throughout the course of this disease. And they are a resource to these patients. They help provide education. They really have an understanding of the disease process and at what points interventions need to be made to prevent the disease from progressing. And we will have patients that will progress, but it's important that they're ready and that they have the information they need so that they can make informed decisions and be part of the shared decision-making process, so that they're making the right decisions for their lifestyle. And that navigator, they build that trusting relationship that really is helpful. And I think that's a piece that has not been utilized in a lot of programs in the past. And it's really beneficial. Patients, they're following up with patients. How many times do you have a nurse call you halfway between your doctor's appointments to check in and see how you're doing? See if something has changed, asking about your medications. I mean, those are some of the things that our nurse navigators are able to do. And we identify a lot of things that affect these patients that we can course correct when we know about them. So it's really a great program to be involved in. There's a lot of work to be done. And like Ray mentioned, 90% of patients with chronic kidney disease are unaware. So there's a huge awareness gap, not just within our health system, but within the country, that there needs to be a lot of work around. Because I think if people have the knowledge, they'll ask for the screening, they'll ask for information about it. And those are really some of our focuses.
I just wanted to ask a follow-up question. You mentioned working with the caregivers of the patients as well. Would you share a little bit about how you're doing that? Because I think that's such an important part of getting the patient on the right journey, having their family and their caregivers involved with that. Absolutely.
We all know that patients need support in in order for them to be successful in what their goals they're trying to accomplish. And so involving family and making sure family is aware of what the plan is, what the situation is really important. And we find that when there is an engaged family member, things go better. So that family support is really important for any patient that has a chronic kidney disease. That's a vital component.
The other thing.
Oh, sorry, go ahead.
Sorry, the other thing I was going to add, just on that point, if I could. So one of the important things to consider as that's part of this program is that when you look at the patient population, the majority of these patients have multiple comorbidities, right? So the two leading causes are hypertension and diabetes. The important thing and the critical thing that Chenlee and her team are doing is they're not only connecting with the patients and their caregivers, but also with the providers. So if they identify that a primary care physician has been working with this patient, they'll proactively actually reach out to the primary care physician before they even reach out to the patient to inform them of our intent of working with the patient. We've identified that this individual hasn't seen a nephrologist and that they need to. And so that's another critical part of this that needs to be considered, that we're not just managing chronic kidney disease or end-stage renal disease in this program, but we're actually, again, looking at all the comorbidities and how do we bring multiple providers together to ensure that all of those different diseases and conditions are being addressed for these patients.
Absolutely.
And I just wanted to point out how that question, thank you for asking that, Terry, it kind of ties into something we just got from the audience, from Jeffrey Rees, which is what types of tools do care navigators use to help patients make the right decisions? And right is in quotation marks because there's always the question of how do we know that the decision is the right decision? How do we know that we're engaging people in actions that they need for care? So I just wanted to throw that out. Chenlee or Ray, what are your thoughts on the question?
So there's a lot of resources. There's a lot of guidance. Intermountain, we've created several tools to help patients have all the information that they need regarding, if they need to make a decision about a modality. If I choose this, what does that look like? If I choose that, what does that look like? And making sure that they understand how it will impact their life. Because, choosing a dialysis modality or a transplant modality or even conservative care all have many, many factors to take into consideration when those decisions are made. And so our navigators use those tools. We've created education that patients can watch virtually, that they can watch with their family multiple times, so that everybody has the information about how these decisions can impact their future.
So it really ties back into some points that you were making earlier with regards to people can't engage their care unless they know that there's an issue and they know the resources available to be able to sometimes if the health, basically to be able to ask the right questions to find the right care.
Yeah.
Mm-hmm. Yeah, and that's the unfortunate thing also with this population, as I'd mentioned before, right? With close to 70% crashing in the hospital, finding out for the first time they have this disease, it really limits the patient's ability to prepare and be informed about what treatment options are available. And it limits those options as well, which is really the unfortunate thing. And that's where most of these patients end up on dialysis in an in-center setting, which, they're potentially, depending on the patient, there could be a better option for them. And that's one of our aims. One of the aims of this program is, in accordance with the, Advancing American Kidney Health Executive Order that was signed last year, we want to get to that 80% of patients on a home dialysis therapy. We know it's a lofty goal, but so far out of our clinic, we've seen almost half of our patients end up on a home therapy because we've been able to engage and identify those patients early on.
And thank you for making that point too, because that's a very large amount of the population that might be uninformed or unknowing of the possibility that they have this illness in the first place. So one thing I wanted to get into is, as hospitals are straddling the line between value-based care and fee-for-service type initiatives, and we really respect a lot of the leadership that Intermountain has done in this area and moving more towards value-based. So what's the impact that value-based initiatives have as you're engaging this population?
So the one thing I would add, so Intermountain, fortunately, we have a system set up in such a way that fosters this transition to value-based care. And by that, I mean, we have a health plan, Select Health. And so as a health system, we have probably just over 40% of the population that we manage that we're at risk for, right? Through our health insurance product. And so as we evaluated the opportunity of making this transition and focusing on this population of patients, it was clear up front that there is something that needs to be done and that there's huge opportunity if we could make this transition to value-based care. One of the, I guess what I would add in that is that it's not an easy transition, right? Even though we have close to 40% of our population of patients at risk, and this program, since this program has been in existence, we still struggle to make that transition, right? Because right now we kind of have 2 feet and a foot in different boats, and so and those boats are going in entirely different directions, and so we're trying to figure out, okay, how do we make this work? And it's definitely a balancing act at this point, but the important thing here is that we know it's the right thing for the patient, right? Regardless of the economics of it, it's the right thing to do for the patient and engaging them early, preventing the progression of the disease, and ensuring that we reduce hospitalizations. We try to get them a preemptive transplant. All of those things have huge economic value in a value-based world. But more importantly, the outcomes for the patients is significantly better than what they have been historically. And that's why I think this disease is getting so much attention right now, is because there has been very little done to get upstream and to take a value-based approach to managing these individuals.
Yeah, and Ray, I would add, there is a lot of attention and it just needs to continue. There is still such a lack of awareness about the disease that I hope that the awareness continues, that the momentum keeps going, and there's awareness campaigns and whatever other formats that can get the word out.
Mm-hmm.
So Ray, just so as you've shifted and you have a foot in 2 boats, how have your metrics changed? Because I know that's a difficult, when you're being measured one way, but the metrics for value-based care are going in a different direction. Mm-hmm. How has that impacted you, and what metrics are you really looking at now?
Yeah, so the way that our program works right now is we do have, a foot in each boat. And so our financial accounting metrics are twofold, right? We're looking at it in the traditional way of productivity for our providers and how they're performing. But more importantly, and what we're entirely focused on is the value of the interactions that our providers are having with patients and what that means to the system and to the patient, right? And so the metrics that we are tracking on a regular basis our aim is to cut hospitalizations in half. If you look at our population of patients, they average about 1.91 hospitalizations per year. We want to cut that in half over the next 7 years. Each hospitalization represents a significant savings to the system from a value-based perspective, right? The other aim of this program is to increase preemptive transplants. Part of the advancing American kidney health is that they want to see a 2-fold increase in the number of transplants done across the nation. We also want to see the same increase within our program. And for every individual that you preemptively transplant that doesn't end up on dialysis, over close to 3 years, it's a $200,000 savings to the system from a value-based perspective. And so it's significant, right? Because we all know dialysis is very expensive as compared to an individual getting transplanted. And again, I keep emphasizing this, but more importantly, it's better for the patient, right? I mean, it's just the right thing to do. And it's amazing how those 2 things line up, right? If you're doing the right thing, the economics will follow. And so that's what makes this so easy. the other things we're looking at are home modalities, right? So like I'd mentioned, we want to get to the 80%. We're currently at about half of our patients have gone on to a home modality, and that represents significant savings as well. We provide those services in-house, and so our cost of providing those services in the patient's home is almost 3 times less expensive than providing those services in the in-center setting. And so again, I think there's a lot of studies that would show that patient satisfaction is much higher, outcomes are better for patients that are being dialyzed at home. And so those are some of like the big opportunities, right? There's a number of other things that we've identified, but those are the main ones that we're really focused on. And of course, disease progression, right? I mean, defining that and tracking that is it is a little bit more tricky, but that is also the aim, right? As we identify these individuals early, we, with the data, we want to be able to prove that we are slowing progression to some degree and what the cost is associated with that.
So looking at the stream of questions coming in, I think they really appreciate the fact that you guys are being open about the goals and some of the audacious and larger goals that you're putting out here, because that gives everybody watching kind of a perspective on where to start and where to focus. So Tani Tran, for example, says that this is a great goal to strive toward. And Kathy Rhodes had a related question, which was, with the goal of 80% on home dialysis, is telemedicine an option for patients and their families? So just curious about how telemedicine or some other newer modalities might be factoring into this as well.
Chenlee, do you want to answer that?
Sure. So we are a tele-enabled clinic, and we are utilizing that platform much more since COVID started, but it can be used for our home patients, allowing them to stay at home and to have those visits virtually with their provider. And it is a huge benefit. There's no question about it.
So when it comes to the outreach and the engagement that you guys are talking about, and also navigating the complexities within value-based care, I know that there's been a lot of talk about data-driven approaches. Could you delve deeper into like if we're looking at this combination of data science and AI and interconnected outreach resources and all that, how does that system actually work? What's the pipe work behind what we're talking about here?
Yeah. So I can give just a high-level overview. Chenlee really is the expert in this area, though, so I'll let her chime in as well. But basically, the 2 main platforms that we're using are MDClone and SymphonyRM's AllTrack. So what we're doing is MDClone has built a data lake in which allows us to be able to, like I'd mentioned before, risk score these individuals and prioritize them. And what we're doing is MDClone then creates a list for us, which is then ingested by AllTrack. Once that list is ingested into the system, then Chenlee and her team are beginning to work that list through from the highest priority patient down. And I'll let Chenlee kind of talk about the details of how that's all working, because it's a beautiful program, and the ability to be able to track these patients has been invaluable.
Yeah, having access to AllTrack is really valuable to us, and the data coming from MDClone, identifying the patients, it doesn't work without that. AllTrack, through a series of workflows, allows us to collect specific data points on patients, and then we can follow the patients as they progress through the disease and kind of look at next best actions about what should be happening at a specific point in time. The navigators have their work list. They can track their patients. They can see them all visually, extremely easily. They can put reminders in and cues them to call them at a specific point in time. And the ability to then create reports is phenomenal, because we can take that data and instantly pull reports, whereas trying to pull reports sometimes from an EMR can be a little challenging. You got to go through the analysts, and it can be a little challenging at times. But with AllTrack, that data is so easy to gather, and so we can see exactly how we're doing. We can see where our referrals are coming from. We can see how many patients are coming to us at what stage in the disease process, and how we might have an impact on that in the future. We can see how many patients are starting dialysis with a tunneled catheter, which is not ideal, as opposed to with a fistula or a graft. And that helps us then know areas that we can focus on to improve. And I think that's really helpful.
The other thing I would add that I kind of skipped over with the MD clone piece of this that people are probably wondering about as far as how do we risk score these patients. So the way that we're doing this, right, in this data lake is we're taking comorbidity clusters, lab values, CPT codes, we're taking claims data. I mean, again, because we're an integrated health system, it makes it ideal and easy for us to be able to pull all this data together to then be able to risk score and prioritize these patients. One of the main things that we're looking at with the risk score of these patients is those that have advanced chronic kidney disease. So we're looking at individuals with stage 3B through 5. And those individuals, per the KDIGO guidelines, are appropriate for a referral to a nephrologist. And what we're finding, again, is that a lot of these patients have not seen a nephrologist. And so those individuals that haven't seen a nephrologist, again, they're at the top of the list. And those are the individuals that Chenlee and her team are reaching out to and engaging.
I see a question out here about AllTrack, and just to clear that up, AllTrack is actually the name that Intermountain gives SymphonyRM's platform. So just to answer that question.
Yeah, sorry for the confusion.
No, that's fine.
we like to put our label on everything, right? I mean, it's just...
So that actually, the question that came in from Jeffrey at HealthBox just got me thinking about the other people that might be looking at this and look at these initiatives. And I'm going to say it, a lot of people will say, well, hey, you're Intermountain, so you're able to do all kinds of stuff. But the real question is, when you've embarked on this value-based care initiative and you've identified, hey, it's an extremely complex process. There's a web of technologies and business processes that we need to be able to integrate to coordinate with the patient. I imagine that there had to have been at some point some organizational resistance, some challenges to being able to get this stuff in place. So could you talk about the journey of what it takes to move an organization in this direction, or perhaps what you guys were doing before that you identified as a challenge to start in this journey?
Yeah, I could provide some insight there. So really what led us on this journey initially was we were looking at whether or not we would participate in the CMS ESCOs, the ESRD Seamless Care Organizations, right? And so as we were evaluating that, and again, we were looking at the data to determine what is the best course of action to take, both clinically and financially. As a system, right, we have several dialysis centers, and we identified, just looking at our own data, that dialysis is very expensive. You know, if you look at the claims data, that's obvious. But what's even more expensive than that is what leads to these individuals ending up on dialysis, right? It's the mismanagement of comorbidities, missed opportunities around managing their diet and their medications and all these other things that are extremely important. And so as a system, again, the philosophy of making this move, everybody was completely aligned and supportive of us doing this. As I'd mentioned before, where it becomes tricky is looking at your financial accounting and performance metrics in a different way, right? From making a transition from fee-for-service to value-based. And that's been probably the biggest challenge for us is making that transition. Fortunately for us, you know, Intermountain has made this journey on a couple of other initiatives. So within primary care, they developed the Reimagine Primary Care Program that has spun off as another program called Castell, which is focused on this type of value-based care in the primary care setting. And so there were some tools and resources within the system that fortunately, you know, exist to help us to make this move. But I think for us, the biggest challenge really has been, you know, the financial accounting and performance metrics and making that transition. And what we've realized is that, you know, and we're still on this journey, right? We're not there by all means, but you kind of have to manage both at the same time while you're making this transition. At least, from an accounting standpoint, but from an operational standpoint, we've completely moved to value-based care. And so all the visits that we do in our clinic, right, we've allotted pretty significant time as compared to what you would see in a traditional clinic for time that providers have with patients. And so from that perspective, we're pretty far down the road and making sure that we're taking a value-based approach to how we're managing these patients. But I think for us and for any organization, right, that's the tough part of making this transition.
And got another question from the audience. This one comes from Mike Leonard, SymphonyRM. So let's talk about just what the limitations of the system are, the capacity constraints. Is there a number of appointments or a maximum number of calls that can be made? What are some of the constraints that you're seeing, and how do you address those?
Well, obviously, people, the more people you have, the more calls you can make, the more people you can see. And so that is, human resources is a bit of a constraint. We're doing well with what we have outlined right now, and we continue to identify efficiencies to make those resources go as far as they possibly can. And that would be one constraint that I would say that we've kind of come across.
Yeah, and unfortunately, there's a large population of patients that exist, right? And so, as Chenlee mentioned, that is our aim, and that's really, at the end of the day, that's what's most important to us, is that we're able to connect with those patients. And in order to do that, you have to have the resources available. I think, again, using the two different platforms that we've used, I think we have the capability to be able to peer into the data and to identify those individuals and begin to do the work. But again, it's the constraints of that, the human resource part of that.
And I just want to chime in. One thing that I'm really excited about our platform being able to reach out, and something we hope to expand with the Kidney Care Program, to be able to reach out digitally, to do emails and texts. Mm-hmm. Because we're constrained by resources, but if you utilize nurture flows so that you can continue to keep the patient informed and let them know what you're doing, and that's where we hope to go with this program and where we've gone with some others. I really believe you just can't continue to put more navigators on it. At some point, when you really want to reach out even to some of the at-risk patients, you'll need to be able to do that electronically.
Mm-hmm. That'll be a huge benefit.
So with the next question that came in, would you like to be engaging more patients? It sounds like you guys answered that in the response, which is, yes, we absolutely want to be engaging as many people as possible, but the system should also identify constraints from a people perspective and an operations perspective, so that we're guaranteeing a good experience and guaranteeing that we can actually deliver on the promise of the care that we're offering.
Mm-hmm. Yeah, definitely. And what I would add is, actually today is the first day we actually have opened our first satellite clinic in the northern part of the state of Utah. And so this is very exciting. And this is, again, one way that we feel like we can utilize our resources is through these satellite clinics. But also, to Terry's point, the other way that we're doing this within our own health system is we are leveraging telehealth to connect with patients that are coming into our hospital that are needing these services. We have several hospitals in very rural communities where historically these individuals would have been transferred to our larger health system, to our larger hospitals, but we're now able to, again, depending on the patient's condition, but we're able to keep some of these patients in their own community by leveraging telehealth and connecting the local providers with one of our nephrologists to consult and to provide some care virtually. So that's been an awesome thing as well.
Well, fantastic. This is a great conversation. And I think we've gone just a little bit over the hour, but if you guys still have some time left, I was hoping that maybe, or if you had some advice for, you answered this a little bit when we were talking about the organizational constraints in your journey, but for people that are excited about this type of platform or this type of approach, but they don't know how to get it started in their organizations, any advice for people that are just now starting to think through how to do this or build coalitions in their organizations? Any advice for leaders that want to bring this kind of experience?
So I guess my personal experience, and again, this has been quite a journey. So this has been a journey that's taken several years. Where we started, again, I mentioned this before, but was mapping out the patient's journey, right? I think that's probably most important, to first understand what is the current patient journey and what are the gaps in care that exist that need to be addressed. And as we did that, right, what we were able to do is completely redesign that patient journey, and not only ensure that that patient was getting the care that they needed when they needed it and across the continuum of care, but also ensuring that they were engaged at the very beginning of that journey. And that was a critical piece that was missing. And that's what I would also add, right, is that, again, it's not about just putting the patient at the center of the care, but it's also getting them involved in the care early, and also their caregivers as well. And that's where I think we've seen a huge increase in engagement and better outcomes. And it's been really a phenomenal thing. But I guess, you know, if you're starting this journey, that would be my advice. And you know, as you build that journey, leveraging data and all of the information that you have to be able to build the case for the need of these services. Again, it was an easy case for us, but each health system is going to be different and have different challenges and barriers, but identifying those is absolutely critical, and being able to figure out, okay, how do we address these in the best way?
Yeah, just having passionate people that really want to make a change.
Fantastic. Any thoughts from you, Terry?
No, I mean, I just want to say what a pleasure Ray and Chenlee have been to work with as their vendor partner. You couldn't ask for better customers who are driving towards great results for their patients. So it's an honor to work with you guys.
I could say the same thing back to you guys.
Thank you. And this conversation has been a pleasure. It's so appreciated, the positivity that you guys are sharing, the fact that you're open about the metrics and the big audacious goals that you're trying to hit. The whole idea behind this was to inspire other people to try to do the same. So thank you for jumping on here and spending some time with us. I know extremely busy with managing this actual work. And just speaking of, what we'll be doing next week is we're going to be shifting the conversation to the physician. Janae Sharp, who is the head of the Sharp Index, which is kind of a data science-driven way to identify patterns that might indicate physician burnout. She'll be talking about what led her to starting this organization and some of the data science around that journey. So look forward to that next Friday. And anybody who has any questions or any topics or comments that they'd like to share, feel free to reach out to us. But with that, we, again, really appreciate the questions and everything that was shared today. So I hope that this has been some good positivity around some tough times. So thank you very much.
Thanks, Chris.
Thank you, Chris.
Thanks, Chris.
Thanks.
Take care.